Thank you for your question. We haven't seen any differences. Actually, we were very surprised by the presence of nociceptors in the cartilage. I remember my first reaction to our findings. I was like crying and screaming to my professor, it's impossible. So then we started to look further, and we found some recordings of the some papers published about the innervation, nociceptive innervation of the discs. And we've found that degenerative discs, they are more vascular, and then they are all supplied by nociceptors. So we could not find any differences between both parts of the joint of any differences in distribution of the nociceptors. We were actually more surprised by the presence of the nociceptors in the cartilage.
Okay, because you are an anesthesiologist, if you want to block the joint, you prefer to block the synovial part or the whole joint?
Well, I've still did not figure it out. What should I do? So I do a lot of things, and I listen to our patients. We discussed it with Professor Hammer already, the contribution of L5 to innervation of sacroiliac joint. When I have a patient in the clinics who complains about the pain in a lower leg, then I also treat the L5 with nerve block with pulse radiofrequency treatment. But nowadays we are using more ultrasound, and therefore we use this posterior sacral network as a reference for our denervation. So usually I do the diagnostic nerve blocks on the posterior sacral network, with or without L5 pulse radiofrequency, and then I do the palisade of the radiofrequency thermal lesion of posterior sacral network.
Thank you.
I have a question. May I ask you, in my experience, some patients with SI joint affection suffer sciatic pain. Your findings that the L5 root innervates the anterior part of the SI joint, could this be an explanation for the sciatic pain? I mean, there's no MRI correlation for the sciatic pain, no foraminal stenosis or something, just SI joint affection, and they suffer sciatic pain. Do you think there's a correlation?
I have noticed experience with a lot of patients. What we sometimes do in patients with sacroiliac joint pain and sciatica, we treat also the piriformis muscle with injection. So we do this diagnostic block on a piriformis. We start with that, and if it helps, we do the Botox infiltration, and then we treat the sacroiliac joint with the regular treatment with diagnostic blocks, and then with radiofrequency.
John, you're muted. We can't hear you.
This is John Stark again, sorry. It's an orthopedic concept, if it's correct, that the basis of SI pain might be osteoarthritis, and the common mechanism of osteoarthritis is interosseous hypertension and microfracture subchondrally, which would suggest that interosseous innervation is important to the pain-generating mechanisms, which might explain why intra-articular injections are not 100% sensitive. Do you have an opinion, or what do you know about nerves that travel with the vessels that might explain osseous pain?
Well, we don't have much information about the history, medical history of our specimens, so we cannot say whether there were regular, normal aging changes or changes of osteoarthritis. So I have no idea actually whether it it has something to do with innervation, in osteoarthritis or normal degenerative changes. I think when we have money, we should repeat our study in some more specimens with known history. We have a lot of patients with osteoarthritis, with Bechterew, for example, or well, inflammatory diseases. So I cannot answer your questions because we don't know it actually.
Thank you.
Niels?
I have another question. I have one more question if there's time. In your beautiful dissections, very impressive. I mean, you must be getting down to the region of the inferior SI joint where the plexus passes and there's this interaction with the superior gluteal artery and that kind of thing. Have you never noticed some compression of the sacroiliac or the lumbar plexus by the SI joint?
Well, as you know, I'm an anesthesiologist.
Oh, I see.
So this dissection was actually a part of my work. I started with dissection, and after dissecting a few cadaveric pelvises, we discussed it with the immunohistochemistry specialist, and it was wiser to switch to immunohistochemistry than let anesthesiologists to dissect the pelvis. So I don't know. I've seen with the with these branches, as you saw on one of my slides, I've seen these small branches, but not any compression, no any specific pathology. No.
Okay, thank you.
May I also add one question? Many thanks for that wonderful talk. It has been great listening to your findings. They have accompanied me for a long time. We do know from other joints, like the hip joint, for example, that as a consequence of pain evolving in those joints, or even as a cause, that substance P carrying fibers, free nerve endings with pain receptive properties, do increase in quantity. We do get more of these fibers in patients that have hip osteoarthritis. I wonder now, and I know this is only hypothetical, but I wonder, what would you hypothesize? Is that the same also for the SI joint? Do fibers grow, spread out, sprout in patients with chronic SI pain?
Well, I cannot imagine that we all have these nociceptors present in our joints. Then we probably all have pain in our pelvis. So I think it has something to do with or degenerative things or diseases or osteoarthritis. But the problem is that I still don't know it because I didn't. Well, I had no chance to look at it because we didn't have any history. So I talked to colleagues, well, some orthopedic surgeons who operate on the osteoarthritic SI joints. When we have some specimens, we can probably make more research about it and in the future find something more about it. But at this point, I have no, I don't know actually.
Many thanks.
Thank you.
So I think we have to go on.